Hello everyone and welcome to our module on nephrolithiasis. Nephrolithiasis refers to a solid stone forming in the urinary tract, and most people call these kidney stones, although in reality the stones can form in the kidneys or the ureters or sometimes in the bladder. And there are 4 different types of stones that form in the urinary system. They're all listed here, and we'll go through them one at a time in this video. Let's start by talking about some of the general symptoms that patients have when they develop a kidney stone and how the diagnosis is made. So the classic symptom of a kidney stone is flank pain, and flank pain means pain on the side of the abdomen between the ribs and the hip. And this is a type of pain that develops when stones are wedged into the upper ureter or the renal pelvis. Some patients have pain in a different location. It can radiate to the groin, inner thigh, or testicle. This happens when the stone is wedged in the lower ureter or at the junction between the ureter and the bladder, which is called the vesico-ureteral junction. Pain from kidney stones is colicky, which means it waxes and wanes in severity. When you treat patients who have kidney stones, you will see that they will describe the pain as coming and going in waves. Kidney stones commonly lead to blood in the urine, which is hematuria. And the best initial test for diagnosis if you suspect a patient has a kidney stone is a non-contrast CT scan of the abdomen and pelvis. This type of study can easily visualize the kidneys and the urinary system, and it can allow you to visualize stones. If you look at this CAT scan on the screen from a patient with a kidney stone, you can see this white dot here in the kidney. That is evidence of a kidney stone. Now, in pregnant women, the best initial test is not a CT scan because you don't want to expose the baby to radiation. So in pregnancy, the diagnostic test of choice for kidney stones is an abdominal ultrasound. This test allows you to visualize the kidneys and the bladder, and it won't show you the kidney stone, but it will show you a swollen kidney, which is hydronephrosis. And that is almost always present when there is a stone because the stone obstructs urine flow and the kidney becomes swollen. You can also order an abdominal ultrasound in a non-pregnant patient if a CT scan is not available. Before there were CAT scans and ultrasounds, the test of choice for kidney stones was an abdominal X-ray, sometimes also called a KUB. In the modern era, this is rarely used, and in a board question, a KUB is almost always the wrong answer. Abdominal X-ray cannot detect hydronephrosis. It also can't see uric acid stones, and it also misses small stones. So in the modern era, abdominal X-rays have been entirely replaced by CAT scans and ultrasounds. And then some other tests that are rarely used are an intravenous pyelogram, which is an invasive test, and an MRI. Neither of these tests is going to be the right answer in a board question. They are rarely used in clinical practice. We'll talk about risk factors for specific types of kidney stones later in this video, but first I want to talk about some general risk factors for all types of kidney stones. And the first one is a high amount of a stone substance in the blood. So patients with hypercalcemia have lots of calcium in the blood. That leads to lots of calcium in the urine, and that predisposes them to calcium stones. And hypercalcemia commonly leads to recurrent calcium kidney stones. The same is true of patients who have hyperuricemia for any reason. They commonly develop uric acid stones. Another general risk factor is low urine volume. Anytime there's a low amount of urine, the concentration of urine substances will increase, and this makes it more likely that these substances will precipitate out of the urine and form stones. And in general, anything that makes you volume depleted will cause the kidneys to hold on to salt and water, and that will lead to less urine volume. So for example, patients who aren't taking in lots of fluid, these patients often develop kidney stones because they have low urine volume. Chronic use of diuretics can make patients volume depleted, and that can over time lead to low urine volume. There's one exception to this. Thiazide diuretics reduce the risk of calcium stones. We'll talk about that later, but in general, diuretics increase the risk of developing kidney stones. And this leads me to a general point about treating all forms of kidney stones. In general, hydration lowers the risk of stones. So for any patient who has developed a kidney stone or recurrent kidney stones, if that patient hydrates well, that's going to reduce the risk that more stones will form. First type of kidney stone that we'll discuss are the calcium stones. Most calcium stones are made of calcium oxalate, but a small minority are made of calcium phosphate. And overall, calcium stones are the most common form of kidney stones. About 80% of kidney stones are made of calcium. Key risk factors are hypercalcemia, as we discussed before, and anything that leads to high oxalate levels. If you have either of these things present, then it's very easy for calcium oxalate stones to form in your urine. And these stones are radio-opaque, meaning they're easy to visualize as white structures on either an X-ray or a CT scan. Let's talk in a little bit more detail about some of the risk factors for calcium stones. The first thing you should know is that the most common etiology of calcium stones is what's called idiopathic hypercalciuria. What this means is that the patient has increased urinary calcium levels, but does not have increased serum calcium levels. In other words, the calcium level is high in the urine, but there's no obvious cause because calcium handling in the body is otherwise normal and the serum calcium level is normal. And this is what most patients have who develop calcium stones. Because high calcium in the urine can lead to calcium stones, then obviously anyone who has hypercalcemia is going to be at risk for calcium stones. So for example, patients with hyperparathyroidism have chronically elevated serum calcium levels. This will lead to chronic elevation of the urinary calcium levels, and that sets them up to develop calcium stones. In the video on renal tubular acidosis, I talk about a type 1 or distal RTA. In this form of renal tubular acidosis, the urine becomes alkaline, and that is a setup for developing the calcium phosphate form of kidney stones, and it's really high yield to remember this. Remember what I told you on the last slide. Most patients with calcium stones form calcium oxalate stones. It's a very small minority that form calcium phosphate stones. But one group that is especially prone to calcium phosphate stones are patients with the rare type 1 RTA, and that's because the urine becomes alkaline, and an alkaline urine is a setup for a calcium phosphate stone. Another important risk factor is high oxalate levels, because remember, as I told you before, most calcium kidney stones are made of calcium oxalate. So who gets high oxalate levels in the plasma? Well, it turns out this often happens to patients who have GI problems like Crohn's disease or who have had a prior gastric bypass. The reason is because these patients do not absorb fat normally. They have fat malabsorption, and fat binds to calcium, and that leaves oxalate free to be absorbed. So the thing to understand is that calcium oxalate forms in your GI tract a lot, and when this forms, the oxalate can't be absorbed and it will go out in the stool. However, if all the calcium is being bound up by fat that's not being absorbed, then the oxalate is free, and that oxalate can be absorbed into the body, and this will give high oxalate levels. So this happens to patients who have some problem absorbing fat. Ethylene glycol is antifreeze, and if patients overdose on this as part of a suicide attempt, ethylene glycol can form oxalate. That will raise the oxalate concentration in the urine, and therefore patients who overdose on ethylene glycol commonly get kidney stones. And then finally, oxalate can be generated from the metabolism of vitamin C, and therefore patients who take high levels of vitamin C can develop kidney stones for this reason. Patients who consume a high level of dietary sodium are at increased risk for developing calcium stones. Let's talk about why that is now. So when you consume lots of sodium, your body holds on to water to balance out the sodium and keep the plasma sodium level normal. This will expand the effective circulating volume, and when that happens, the renin-angiotensin-aldosterone system will be dialed down. Because of decreased activity of the rest, there's less sodium reabsorption from the proximal tubule, and calcium reabsorption is tied to sodium reabsorption in the proximal tubule, so there will also be less calcium reabsorption of the proximal tubule. This will leave more calcium in the urine and set patients up for calcium stones because they are consuming a high sodium diet. So this is a key principle of treatment of calcium kidney stones. More sodium intake equals more calcium in the urine. So patients who consume a high sodium diet are at increased risk for stone formation. Conversely, a low sodium diet can be used to treat kidney stones. And in patients who have recurrent calcium kidney stones, one of the recommendations is to eat a low sodium diet for this reason. So the classic case of a patient with a calcium kidney stone is a patient drinking less water for some reason. That patient develops colicky, flank pain, and hematuria. There's a calcium stone on the CT scan, but the plasma calcium level is normal. However, if you measure the urinary calcium level, it will be high. This patient has idiopathic hypercalciuria, the most common cause of calcium kidney stones. The treatment for calcium kidney stones is fluids and pain control. Pain control is usually done with NSAIDs. Fluids can be oral fluids or intravenous fluids if the patient is in the emergency room or the hospital. And if you administer fluids and pain control, most stones will pass on their own. Large stones that don't pass require surgery, and we'll talk about that in a minute. There are also two medications that are sometimes administered to help large stones pass. These are nifedipine and tamsulosin. Both of these can function as antispasmodics. What they do is cause relaxation of smooth muscle in the ureters, and that can sometimes help larger stones to pass. Nifedipine, you may know, is also used for hypertension. It's a dihydropyridine calcium channel blocker, and tamsulosin is sometimes used for men who have benign prostatic hypertrophy. It's an alpha blocker. Large stones that won't pass can be treated with lithotripsy. This is a procedure where shock waves are transmitted through the body to break up the stone to allow it to pass in smaller fragments. And shown on the screen is a general algorithm for how stones are managed. Stones that are less than 5 millimeters are very small, and these will usually pass on their own. Patients only require pain control and fluids. 5 to 10 millimeters is a medium range. In this range, antispasmodics are used, and in some places lithotripsy is used as well. And then stones that are more than 10 millimeters are large, and these usually require lithotripsy. For patients that form recurrent calcium stones, there are a couple of treatments that can be administered to lower the likelihood that they will have more stones. The first one are dietary modifications, and we've already talked about a number of these. Patients who have recurrent calcium stones should keep their fluid intake up, they should eat less sodium, they should limit their oxalate intake, and they should avoid consuming excess vitamin C. One thing you should know, however, especially for your boards, is that calcium restriction is not recommended. And the reason is because of what I said before. Remember that calcium binds oxalate in the gut, and then calcium oxalate goes out in the stool. So if patients consume less calcium, there will be more free oxalate that will be absorbed, and this can increase the risk of stones. So although oxalate intake should be limited in patients with recurrent stones, calcium restriction is not recommended for this reason. Some other treatments for recurrent calcium stones are shown in this slide. The first one is thiazide diuretics. So one of the effects of thiazide diuretics is to pull calcium from the urine, and they can cause a mild hypercalcemia. And for this reason, they're useful in patients who have lots of calcium kidney stones because they decrease the amount of calcium in the urine. Another treatment is citrate, which is a supplement usually taken as potassium citrate. And the reason citrate is beneficial is because when it gets into the urine, it binds with calcium but remains dissolved. And this lowers the amount of free urinary calcium that's available to form stones, and therefore this inhibits stone formation. And you can get citrate as a supplement like potassium citrate shown on the screen here. You can also get it by eating more fruits and vegetables which have lots of citrate. So dietary recommendations to eat lots of fruits and vegetables are also an element of treating patients with recurrent calcium stones. Okay, so the most common form of kidney stone is a calcium stone, usually made up of calcium oxalate. But for the remainder of this video, what I'm going to do is talk about some of the other type of kidney stones that are less common, and we'll start by talking about struvite stones. Struvite stones are made up of ammonium, magnesium, and phosphate, and they're the second most common type of kidney stone, responsible for about 15% of cases. And there's only one way that you can get a struvite stone, and that is if you have a urinary tract infection with a urease positive bacteria. In order to form a struvite stone, you need to have excess ammonia in the urine plus a high pH. Let's look at the bottom right side of the screen. So urea is always found in urine, and urease positive bacteria can turn urea into ammonia and carbon dioxide. Ammonia can then pick up a proton and become ammonium, and ammonium is a key component of struvite stones. So only when you have urease positive bacteria are you going to get enough ammonium in the urine to form a struvite stone. Now, the most common cause of urinary tract infections is E. coli, and E. coli is not a urease positive bacteria. So most patients with urinary infections are not at risk for struvite stones. It's only patients who have urinary infections from some of the less common causes of UTIs, bugs like Proteus or Klebsiella, that are going to have an infection with a urease positive bacteria that can cause a struvite stone. And as I just talked about, these bacteria, Proteus and Klebsiella, are urease positive. They hydrolyze urea to ammonia. They also make the urine alkaline, and this is a setup for struvite stones. Struvite stones can form staghorn calculi, which occurs when little bits of stone precipitate and form a cast of the renal pelvis and calyces. It will look like the horns of a stag on X-ray. This is an example of a staghorn calculi by X-ray shown on the screen here. What's happening is little bits of stone have precipitated from the urine and coated the walls of the renal pelvis, and that makes this cast that looks like the horns of a stag. Staghorn calculi are so big that they obviously are not going to pass naturally, and surgery is required. If left untreated, they become a reservoir for bacteria, and recurrent infection can occur, and therefore these are always treated with surgery. And as you can see in this image on the screen, struvite stones are radio-opaque. You can see them on X-ray and CAT scan. So the classic presentation of a patient with a struvite stone is going to be someone who has a history of UTI symptoms like dysuria and frequency. They may have mild flank pain from the kidney stone. They will have hematuria, and then imaging will show a large branching staghorn stone. And the treatment is surgery to remove the stone material plus antibiotics to treat the bacterial infection. Next type of stones are uric acid stones, and these occur anytime there's a high concentration of uric acid in the urine or if the urine becomes acidic. So if you look at this equation on the screen, uric acid is made when a proton combines with urate, and urate is soluble in the urine. So anytime there's an excess of protons, that is going to shift this equation this way and make more uric acid, and therefore acidic urine is a risk factor for uric acid stones. In addition, if there's simply a high concentration of uric acid in the urine, that also makes it more likely a stone will form. And in contrast to calcium and struvite stones, uric acid stones are radiolucent, which means you can't see them on X-ray. This was a problem in the era before CAT scans, but now we have CAT scans, and CAT scans can see uric acid stones. So risk factors, as we just said, are high uric acid levels. So who has high uric acid levels? Well, many patients with gout have a high level of uric acid in the plasma and the urine. This is a picture of a patient who has gout with inflammation of the big toe. Patients who have leukemia have high rates of cell turnover, which can lead to high levels of uric acid. The same is true of patients who have myeloproliferative diseases. Acidic urine also increases the risk of uric acid stones, so patients who have chronic diarrhea, for example, will have a chronic acidosis, and that can increase the risk of uric acid stones. And then finally, uric acid stones are more common in certain areas of the globe, usually areas where there's a hot, arid climate. People in these regions tend to have a low urine volume, so they're relatively dehydrated, and acidic urine is more common based on the diets that people eat. So for example, in the US and Europe, only 5 to 10% of stones are uric acid stones, but there are some other climates and some other countries where up to 40% of stones are made of uric acid. The treatment for uric acid stones is hydration plus alkalinization of the urine, usually with potassium bicarbonate, and this is super high yield to remember for your boards. You usually do not need to treat uric acid stones with surgery. That's because, once again, if you look at this equation on the bottom of the screen, if you decrease the concentration of protons in the urine, meaning if you make the urine alkaline, then this equation will move in this direction and all of the uric acid will turn into urate, which is soluble in water and therefore soluble in urine. So therefore, medical therapy with alkalinization of the urine usually treats uric acid stones. Rarely patients require allopurinol. It's a xanthine oxidase inhibitor, which reduces uric acid production. But once again, the key point to remember about these stones for your boards is that medical therapy is often effective and these stones usually do not require surgery. So the classic case of uric acid stone is a patient who has flank pain, hematuria. On x-ray, there's no stone. The patient has a history of something that can lead to high uric acid levels like gout, leukemia, or myeloproliferative disease. And then once again, choose medical therapy, not surgery, for the treatment of the uric acid stone. Our final type of kidney stone is a cystine stone. This is a very rare type of kidney stone. If you look at the right side of the screen, cysteine is an amino acid, and when two cysteines combine together, they form cysteine. And this commonly happens when cysteine is in the urine. It will bond together with another molecule of cysteine, and cysteine will form. Now, most of us can reabsorb the amino acid cysteine, so we don't get high levels of cysteine in the urine, but there's one exception to that. Some children are born with a rare condition called cystinuria. This is a tubular defect where they cannot absorb the amino acid cysteine, so high levels of cysteine accumulate in the urine, and this can lead to cystine stones. Cystinuria is a condition that only causes one problem, and that's kidney stones. These are the patients who get cystine stones. Like uric acid, cystine stones are radiolucent, so you can't see them on x-ray, but they are visible on CT scan just like all kidney stones. So the classic case of a cystine stone to know for your boards is a child who has recurrent kidney stones. There may be a family history of kidney stones because cystinuria is an inherited disorder. Classically, the urine has a rotten egg odor, and in urinalysis what you see are hexagonal cystine crystals in the sediment. This is a picture of what they look like on the screen here. The diagnosis is through a test called the sodium cyanide nitroprusside test. The way this test works is the cyanide converts cysteine into cysteine, and cysteine binds to nitroprusside and turns the urine a purple color, and that's a positive test. And the treatment for cystine stones is very similar to the treatment for uric acid stones. It involves hydration and alkalinization of the urine. Alkalizing the urine increases the solubility of cysteine, and that makes it less likely that stones will form. And for children who have this disorder, they often have to take bicarbonate on a regular basis to keep their urine alkaline and prevent stones from forming. And that concludes our video on nephrolithiasis.